If you are into injury prevention, then save this date in your calendar. It's Monaco, and it's the IOC World Conference on Injury and Illness Prevention, and it promises to be an absolute humdinger again. Now, this is the title of our talk this morning, The Injury Prevention Myth. And I'd like to talk a little bit about how we now approach injury prevention, the shift that we're experiencing and have experienced for a while towards risk management. Now, I've dressed up a little bit, and this is mainly the reason. Because on Saturday, South Africa became the Rugby World Champions for the third time. And it was incredible. Rugby has been an incredible catalyst. And I think it's an example of what sport can do in a country. In 1995, Nelson Mandela used rugby to completely change the narrative of our nation. And in Japan, Siya Kolisi became our first black captain. For a country like South Africa, this is a massive moment of transformation. And he was incredibly gracious in everything, but we are so proud of what the boys achieved in Japan. We really couldn't be prouder, and that's why I've suit and tied today. But it kind of reminded me as well that this is the game we're in. On that podium there was the team, and the backup team, and the sports and medicine physician, and the physio, and the trainer. And everybody's on that podium, and we all get measured by this single thing. In elite sport, we want to help our athletes to achieve their optimal performance. That's in our vision statement. And that's really our game. The main thing is to perform at your optimal level. And as Stephen Covey said, the main thing is to keep the main thing the main thing. So with that in mind, is injury prevention a myth? Are we really trying to prevent injuries? Do we care if we get injuries if that doesn't influence performance? Now, that's what we're going to talk about today, but to answer that, I thought I'd talk about my favorite myth, which is the space pen. So the story goes that NASA spent millions of dollars developing a pen to write in space. So that's kind of hard because of the anti-gravity, and you have to get a very pressurized system, and it's a whole thing. Millions and millions of dollars, while their Russian counterparts found a much simpler solution. Now, that's not exactly true. Everybody was using pencils. Pencils are actually quite a problem because of the lead, and it breaks down, and it's not great. And the Fisher Pen Company spent millions of dollars to develop a space pen. And in the end, NASA did buy the pen. But so the myth that was created around this is not exactly true. So myths are stories that has a little bit of truth in them, but they're not always 100% truthful. Now, this was before the 2015 World Cup. Jean de Villiers, the inside center, who's also the captain of the team, for my mind, the best inside center of his generation. Sorry, Athol. And in this game against Wales, it's about 6 months before the World Cup, he has this catastrophic injury. The referee actually stops the game. And on the video, you can actually hear him scream. So René's there with him, and if you look at his left knee there, you can see how it gets into this really awkward position. So massive trauma, he gets surgery, we push him back. He actually captains the team in 2015, breaks his jaw in the second game, doesn't play much else. We lose to New Zealand in the semi-final by 2 points. Now that's hard to prevent, right? I mean, that's a really difficult situation. Now, this is Jean, and this video got a lot of attention back home just this year. Can we turn the sound up, please? Because Rod messed up my slides because they were ready to go. But anyway, so Jean says his knee isn't feeling great. It's a bit loose.
I should be fine. My swing's looking good.
But his golf swing still looks okay. Now, did we fail him? He was able to compete in multiple World Cups. He won in 2007, but had a horrific run of injuries. But was our injury prevention, was our management of this player a fail, or was that just the unintended outcome of what essentially was still a good risk management program? So to answer that a little bit better, let's think about what we mean by prevention. So in general health, it's a little different, right? We've come a long way, haven't we? But for smoking is a really easy example because we know that there's a big association with lung cancer. And so all we do is we remove the exposure. It's really simple. So we don't try and figure out, just everybody stop smoking. And that's largely been successful. But in sport, we can't do that. We can't remove, well, we could, right? I could put a speed limit on football games, but it would be super boring. So we can't really do that. So in football, or in sport, we're trying to figure out exactly how many cigarettes can you smoke before you might get ill or injured. So that's a completely different way of approaching prevention. So I thought, okay, so if we're doing it differently, what have we done? Let's look a little bit at the history of how injury prevention has developed. So the first really landmark moment was Willem van Mechelen's paper in 1992, and you've all seen this now, right? The sequence of prevention is often called the van Mechelen model. So you establish the magnitude of the problem, you try and look for risks, factors, or causes, you come up with an idea to prevent the injury, you implement that idea, and then you test, again, the magnitude of the problem to see if you've made it a little smaller. It's a really simple program, but as the clinicians in the room will say, well, hang on, that's a research model, right? That doesn't help to explain to me how injuries work. So at the same time, in 1994, Willem Mjøvisse came up with this model, the multifactorial causation model. So you have an athlete that is predisposed by intrinsic risk factors. He's then exposed to some external risk factors and makes him a susceptible athlete. There's an event that leads to an injury. So really simple, really easy model to follow. Then about 12 years later, oops, did I go too fast? Yeah, so about 12 years later, he said, hang on, we can actually probably upgrade that a bit. Because there is an inciting event, that's true, but there's lots of events that lead to no injury. And when you have an injury, you recover, and then there's back to the no injury status, back to your old previous status. But there might also then be an adaptation that changes how these risk factors influence your risk of injury. Roald Barr and Trond Krosshaug also then draw our attention to the fact that the mechanism of injury seems to be really important. That happens really close to the injury, but the risk factors we test are often far away from the injury. And then about another 12 years later, we've had another update. So applying this kind of thinking in a team sports environment, bringing workload into the mix. But by far the most influential paper has been Natalia Bittencourt's complex systems approach. So again, we have these factors, but now we're saying, hey, hang on, they interact. They actually might influence each other. Your weight might influence your strength, and that might change what that risk represents for you. And all these interactions will lead to some regularity. That forms a risk profile, and that then either leads to an injury or an adaptation, and you feed back into the loop. Now, this is a really important shift because I think we all agree with that. Injuries are complex, they're multifactorial. There are a ton of things that influence how things may or may not occur. And this is true in this game where Toulon plays in the French league, one of the top rugby leagues in the world. So if you watch the bottom screen here, it doesn't turn out good for someone on the field. Although they do go on to score a try, so that's no influence, luckily. But I'll play that again. If you just watch the physio in the bottom corner here, he's trying his best, but couldn't predict that, right? Because injuries are complex. They're complex things. Now, Natalia said to better help us understand this complexity, we need to move away from these isolated risk factor findings and try and identify patterns. So the more perceptive of you might have noticed the trend here, right? Because in 1995, South Africa won the World Cup. And then 12 years later, in 2007, we won the World Cup. And now, in 2019, we've done it. Have I mentioned South Africa won the World Cup? So there's a clear pattern here, although I hope we don't wait another 12 years for the next one. So this begs the question, do we really need more models? I don't think so. I think what we're after now is a way for us to understand how to implement an effective risk management strategy. And so Colin Fuller did this really incredibly valuable work, also in rugby coincidentally, where he brought the research they were doing in industry into the sports medicine world. So a very similar three-stage process here. We identify risk factors, and that's influenced by injury surveillance and epidemiological studies. We then estimate that risk, and we're going to talk a little bit about that because we need to understand what that risk represents. And then that happens in a certain context. Certain players, certain times of the year, certain seasons are different. And so we have to include that risk perception on whether that, and when we evaluate what we're going to do about that. So if there's an acceptable level of risk, we communicate that, no problem. If there's an unacceptable level of risk, we're going to try and implement strategies to mitigate that, whether that's injury prevention or therapeutic approaches. So I really like Colin's model, and I think it went even a step better, or with respect, maybe simplified a little bit when Roald and Andy McIntosh published this in Sports Injury Prevention. So this is a four-step process that essentially captures that framework. So this first step is to come up with your injury surveillance data for the team as it relates to the league. So the question there is, what are the risks in my team? Are they unique? The second step is to do an analysis of what you're planning to do over that season and what you've done before, perhaps how the competition is going to influence that. In an Olympic year like next year, that will definitely change, right? So does the risk change throughout the season? Can we actually measure that? The third step, and that's where I'll concentrate most of the rest of the talk on, is can we identify athletes that are perhaps at a higher or lower risk of injury through our screening or periodic health evaluation process? And then, the $3,640,000 real question, or $1 million question, I messed that up. Should we do something about it, right? Because if it doesn't lead to anything, we're good. So are we actually going to change anything we do? So this is an effective risk management program, and we'll use this as the outline for the talk. And we'll try and answer these questions with some practical and clinically relevant examples. So if we think about the risks in my team, a couple of years ago, Roald and Jan with Ben Clarkson wrote a really important paper highlighting the burden of injury. So we often think about severity, which is on the y-axis, and we often think about incidence on the x-axis. But if we combine them, we can see that an injury like ACLs don't happen that often, but they have a huge severity component. Usually the athlete's out for the rest of the season, maybe longer. So that we really will look at those differently than, for instance, hamstring injuries, who happen quite a lot, but it's 2 to 3 weeks and then they're back. So we might accept the risk associated with those two injuries in a different way. We might approach strategies to mitigate that risk differently. Now, I'm currently part of ASPREV, our injury prevention program, with Professor Karim Shumari and Montasser Taban, as well as Eirik, Olivier Materna just joined us, and Rima. And Olaf, of course. And so I don't think the team would mind if I highlight Montasser's contribution to these reports that are being produced every year. So this gives every team an idea of what they're doing compared to the rest of the league. And so if we look at one team, for instance, you can see that here in 2014, they were really underperforming in terms of their injury burden. So they had a higher injury burden than the rest of the league. But over the next couple of seasons, they seem to have been doing something right, because their injuries have definitely dropped down. So this helps you to understand and evaluate whether what you're doing in your team is different, and if your team actually have different types of risks that you need to address differently. Good, so we can answer that. Then, does risk change throughout the season? Now, I think it would be wrong not to mention the work of Tim Cabot, because as Rod often highlights, just a few years ago, we were still doing Biodex tests and making sure that people are strong, right? Because that's going to definitely keep everybody healthy. And Tim has broken open the field of how workload is related to injury risk. Now, there's a lot of criticism about this particular paper. If you haven't read it yet, it's open access in BJSM. Please do, because he brings to the fore some ideas about how we can interpret workload or training load in relation to injury risk. Now, there's a lot of criticism about this at the moment, and rightly so. We need to think about what we're doing and whether we are doing what we say we're doing, or we're measuring what we say we're measuring. But in this paper, Tim proposes an acute-chronic workload ratio. Now, acute as in, what have you done this week, for instance? How much can I fatigue you? How much can I push you? Versus, what have you done over the last 4 weeks? Chronic workload, how fit are you? And it makes sense, right, that those two things would be linked. He proposed a cutoff of 1.5. So if you go over the 1.5 margin, you're a maverick, because then you're going into the danger zone. Top Gun fans? No? Okay, so I can't not think of Top Gun when I hear danger zone. So you want to stay in the sweet spot. Now, even Tim has shown that that's actually not exactly right, that a lot of things mitigate this. If we think about the acute chronic workload ratio and how that spikes over 1.5, actually we might explain that just by chronic load. So if your chronic workload increases enough, you might mitigate your acute workload risk, right? So just to say, and there's some really good criticisms and debate around this now, but I think this has really helped us to think about how workload might influence injury risk, and we're going to contribute to that. So we've started a collaboration between Aspire and Aspetar, which we've called the WIN project. So looking at this relationship, this is the group that is representative of exercise scientists, physios, physicians, managers, even podiatrists. So we're really representative of the whole spectrum of what could influence injury or workload. And we're proud to say that our first study has now been published, with Lorenzo Lolli taking the lead on this one. We looked at session RPE, so rate of perceived exertion, and found no real association with hamstring injuries. So again, if you look at the session RPE plotted on the y-axis, the days to injury on the x-axis, so day 0 is right in the corner here where the injury happens, kind of looks like there's a trend. But if you look at the black dots, there's so much variability in this data. So that really doesn't help us to make any clinically meaningful statement. But this is the kind of work that we're really interested in now, to see if we can establish where these patterns change and where your risk of injury might be increased. Right, so can we identify athletes that are at higher risk of injury? Is there stuff we can do to determine risk for certain athletes or lower risk of injury? Now, this is where I've been living for the last 6 years. This is the title of my PhD, and here Eric Wittfro, my main supervisor, and Roald awards my PhD that I completed through the University of Ghent in Belgium. So I look pretty happy about that, right? So 6 years is a long time. If you're not interested in the 6-year process, I found this really cheap alternative. So it looks like you can just get some PhD bars. They're available at SPA now, and they've actually shown me I've got a pretty medium, I would say average size head, so it looks like my brain is worth about 250 reals a kilogram, which is disappointing. I've been overpaying, but you can find your PhD bars. Otherwise, you need to do a study. You need to go and do a project, and that's what we did. This is what our musculoskeletal screening battery looked like for about 3 or 4 seasons. And before that, we had already done isokinetic testing. This is the assessment center now, so it looks already a little different than this. We've upgraded again, but Rula and Vas are doing an amazing job, and we've shifted away from our old testing to include more dynamic force-related testing. So it's going to be really exciting to see what happens here. But for our project, when we looked at risk factors, we did some isokinetic dynamometry. So you guys have seen this or are familiar with it. If you're not, that's a pretty standard isokinetic battery of tests. We looked at forms of flexibility, so knee to wall and posterior thigh testing. And we looked at some specific neuromuscular function tests, onset of muscle activity and rate of force development. We were also able to include some pretty novel testing at that time. This is more commonplace now, but the Nord board was used in some of our strength testing. So over 6 seasons, we were able to test over 800 players, more than 250 hamstring injuries, and more than 4,000 actual tests. So if you disagree with what I'm about to tell you, that's all you have to do, and then you're welcome to give us your opinion. But this is what we found. So eccentric hamstring strength, concentric quad strength. Yep, there's an association with injury. Ankle range of motion and hamstring flexibility. Yep. Neuromuscular or 2 neuromuscular tests, no. So maybe that's a product of the injury. But definitely, and that's great, right? So strength and flexibility, that's stuff I can work on, no problem. So really easy. I've plotted the injured players in red and the uninjured players in blue. And so from our data, you can see the proportion of players there and their body hamstring strength normalized to body weight. Everybody above the line's fine. I just have to worry about the guys below the line because they're the ones that get injured. Easy, right? Nah, that's not it, because that's what it looks like. So the injured and the uninjured players almost completely overlap. And so it's really hard to say whether a player will be in either group. If you're strong or kind of weak, you might end up in the injured or the uninjured group. Now, what is that? How do we interpret that? Because it means that this group finding can't be translated to individual risk. Well, at least not directly. Or you could put it a different way. If we think about clinical validity, so we've established a robust relationship. It's a pretty big data set, and we can see that there's something there. But that hasn't led us to clinical utility. The so what, the who cares question. What does this change in my practice? Or as Paul Reed might say, what does it all mean, Basil? So what it means is we can't predict who will get injured. And if you don't believe me, read Ruold's paper. It's a great expose about why this isn't possible. Right? But screening is useful for many other things, right? Especially establishing baselines and detecting ongoing musculoskeletal problems. So if we can't directly translate it, how do we interpret this? Now, I'll turn to one of my favorite scientists from Ron Burgundy's group, who says 60% of the time it works every time. So that's often how we think about predictions, isn't it? So if there's an 80% chance of rain tomorrow, it's going to rain tomorrow. It's like, well, that's not exactly true. That same prediction is saying there's a 20% chance it won't rain. So whether it rains or not, that forecast is true. Now, so it's important to distinguish between that forecasting, and then the other thing is to understand how risk actually changes. What's the real change, if I can put it that way? And this is best explained by my favorite example in statistics, where the World Health Organization brought out this recommendation. If you eat more than 2 slices of bacon a day, that's a lot of bacon, I think, anyway, but okay, so 2 slices of bacon a day, your risk of colorectal cancer goes up by 18%. Now, that sounds like a big deal. The media goes kind of nuts, like we all have to stop doing this. But if we go and look at the study, or if we try and interpret that risk, maybe that's not exactly what happened. So this is from the paper, the table from the paper. That is the 18%. That's true. So good job. They reported that correctly, and the confidence interval is kind of neat. But first, I want to know, what is my risk of getting colorectal cancer anyway? So it turns out that's about 5%. Now, if I apply that hazard ratio to that list, so how more likely am I now? It only changes to about 6%. So 95% unlikely to 94% unlikely. Cancer is a big deal. That 1% might matter to you. It certainly doesn't matter to me. That's the same. So the actual change, the absolute change, isn't that much. So this is called Bayesian inference. If you're not familiar with it, you start with a prior probability, you have a likelihood, and then you end up with a posterior probability. So if we do that with our hamstrings, the chances of getting a hamstring injury in our league is around 11%. For eccentric strength, hamstring strength, the odds ratio was 1.37. So there's a 37% increase in risk, and that changes the risk of hamstring injury to 14.6%. So that's the relative risk of injury. That still sounds like a big deal, but if you look at the 11 and 14%, the absolute risk of injury is only a 3.5% increase. So again, that's probably not that useful. But if you now take this posterior probability, make it your prior, then you can start to build a risk profile for a player or a team. And all this information adds up. We do that all the time, don't we? When you assess a patient, those bits of information helps you build your hypothesis until you come to a certain amount of certainty, although there might be some uncertainty about what's going to happen. So I'll give you another example. Let's pretend, just for a minute, that we didn't know who won the World Cup on Saturday. So it's going to be either England or South Africa. So if you know nothing about rugby, you might say, oh, I don't know, both teams looks pretty good to me. I'll say 50-50. Now we'll go and look at the rankings. England at that stage was still ahead. So we'll say, okay, well, probably we'll give this to England for now. Then you read that there's been some injuries in the South African team. So, that doesn't look great. They're already playing with less good players potentially. So we'll still give it to England. Still not sure. So you ask a guy who knows a lot about rugby, and you can tell by the tie he's wearing. And he's convinced South Africa is going to win, but he's pretty biased, right? So his opinion is not going to influence what I think here. And luckily, that prediction was completely wrong. Have I mentioned that South Africa won the World Cup? So we can do this in injury prevention as well. And a good example of this is what they've done in Oslo, the work of Ben Klaassen with their group at Olympiatoppen, where he developed the overuse injury questionnaire. So athletes are asked to report on these 4 categories: participation, performance, training or competition, and pain. And then this is all available on an app. So they've done a lot of hard work to make the technology easy. That's vital. That's key, right? The technology has to work. So then the report, and then they come up with a certain score for that day or that week. Now, over time, you're able then to build a pattern for a player. And you can see where things change for that player. So if he gets to 60, it looks like we're going in the wrong direction. So every time he gets to 60, we'll try and intervene, or could potentially intervene. So if we go back to our risk understanding, if we think about our weather prediction. Now, if there's an 80% chance of rain tomorrow, there's not, so don't worry, but if there were, then you'd probably take your umbrella, right? But if it doesn't rain tomorrow, you're okay with that. You know, you're not really that mad that you have your umbrella with you. If there's a 20% chance of rain tomorrow, you probably won't take your umbrella. But if it then does rain, you're probably okay with that too, because you understood that there was a small chance and that you were happy to take that risk. So in both those scenarios, you made two completely different choices, two completely different decisions that led to completely different outcomes, and you're probably happy with that process. So I think this is where we need to end up, with a shared decision-making process that embraces some amount of uncertainty and complexity. But risk management that is ultimately outcome independent. We can only manage risk. We cannot predict outcome. And in sports especially, we are purposefully exposing our athletes to that risk. And we need to come up with tools that have clinical utility. Stuff that we can do, that we can measure, that we know is changing something. Right, so now for the real question, should we do something about it? Well, I would argue that we already are. So if we think about prevention, you can do something at a primary level that's almost like a vaccine, right? So everybody gets it. You can do something at a secondary level where you're trying to address ongoing or current issues or even previous issues. Or at a tertiary level, our rehabilitation is really important to prevent re-injuries. Now, at a primary level, there is undeniable evidence for this exercise. I won't go on about it too long. We've did a systematic review at the beginning of the year, and it's free now in BJSM as well. But we took all the papers that looked at this. So if you're doing systematic reviews, this is not the way to do it, right? Because there's way too much heterogeneity. But we actually wanted that because we were looking for something to shift this diamond, to get rid of it. And nothing really did. So across the board, right, and of course you have to apply this to your setting. It's not going to be true for every single athlete. But Nordics reduces hamstring injuries. So at a primary level, we have a really good example of how we can be effective. We've also built this into an interactive tool. So this is tagged to my Twitter account. So if you click on the link, it brings you here. And you can go and play around with the different elements that changes the risk profile. So that's kind of a neat thing to do if you're thinking, oh, I really only want to look at the high or the low risk of bias studies or whatever. So I encourage you to do that. Then just a couple of weeks ago, Martin Wallen published his secondary prevention program. So I'm going to go through this framework with you because I think it's really, it's a very interesting way and a good example of how screening or monitoring, if you will, is still very effective. So they decided to put in an alert. So they did isometric hamstring testing, and if you were over 14%, you got an alert. So no alert, normal training. If there was an alert, you were retested in the afternoon. If your strength was then restored, back to normal training, no problem. If it wasn't, you got a clinical examination, right? So that's just screening up until that point. So clinical examination, maybe we've missed something, and if you have an injury, obviously you go into your rehab process, and as you recover, back into our monitoring system. If there's no injury, they described it as a subclinical stage, where we then have a conversation with the performance team. So, hey, are we going to change something here? We think there might be a risk. Will you be willing to reduce the workload, have a rest day, change the strengthening, something? So there's still an evaluative component to this, and Martin had very low number of injuries, but I think this is promising work to show us that our ongoing monitoring of athletes can actually be effective in preventing injuries. And then at a tertiary level, at a rehab level, we actually found something really surprising in our study. So in the first paper we published looking at 4 seasons, previous injury, which is a very strong risk factor as you know, was found associated with hamstring injuries. But in the last 2 seasons, it disappears. It's like, well, how is that possible? Like this strong risk factor that suddenly just goes away. Well, when we thought about it, we're in a pretty unique environment here, right? There's a real kind of synergy in what we do. And so we had a randomized controlled trial start in 2010, and when that one finished, we started a second one. And our colleagues at the NSMP were gracious in letting us treat a lot of those athletes here at Aspetar. So we were able to control the rehab, and that filtered back to the clubs, of course. So we were able to give everybody, for a large number of years, a really good deal. So it seemed like if we do a good job, we can actually mitigate the risk associated with previous injury. So that's a big deal for us. So we can, if we do a good job in rehab, we can actually have an influence in injury prevention. So at each level, I think we have good evidence that we can influence this process. And that's really important. So we end up with this really nice summary of a risk management program. Now, just to emphasize again, I've borrowed this by and large from the incredible work by Roald Barr and some of his colleagues. But what we want to end up with is an understanding of the risks within our own team and whether those risks are different. We want to have quality injury surveillance. I think we're all focused on data now, but it's really the quality of the data that will determine how well we can answer some of our questions. And then we want clinical monitoring that leads to action. We want to have outcomes that we can measure. We want to do things that where we know whether we've influenced change or not. And ultimately end up with an integrated health performance management model. So the last thing then, if we think about our risk management program and we think about Jean de Villiers at the start of the video with his very loose knee. Now, interestingly, the Springboks, our captain Siya Kolisi, also had a major knee injury at the beginning or prior to the World Cup. And so for both these players, we tried to do our best in terms of managing that risk. Both Jean and Siya were pushed to get back to the World Cup, and we knew the importance of what it would mean to have them both there. Unfortunately, with slightly different outcomes, where we didn't win in 2015, but were victorious now in 2019. So Rassie Erasmus, the coach of the Springboks, he knew how important it was for this team to have the captain there. And he knew that he'd have to implement a management system of both this player but the team that will lead to a successful outcome. So this was the motto of the Springboks leading into the World Cup. And it was really this unifying message for our country, but it ended up also being a unifying message for the team. Because every person in this team, from the coach right down through to the support staff, knew what their role was going to be. The reserves that came on, or the substitutes that came on later in the game, they had a very specific purpose for when they got onto the field. So everyone in this team knew what their role was. They were given authority to lead from within their role and make it their own. And that's vital. In the final of the World Cup, Siya Kolisi, with 20 minutes to go, is substituted. Because we have this plan, and he's the kind of leader under the direction of Coach Erasmus who can step back and understands that it's also important to let the others lead, to be there for each other. Now, this is true whether you're a department, a federation, a hospital, or a World Cup elite sports team. When we're all working together, when we're allowed to appreciate each other, when we share respect and trust each other, is when we can achieve at our highest level. And I think that was very, very true of this team. And that's how I would want to see the future, where everyone is working together as Paul Dijkstra would call it, in an integrated health performance coaching model. That's when we can achieve our best and ultimately help our athletes, support our athletes to focus on the main thing, which is performance. And the main thing is to keep the main thing the main thing. So thank you all for sharing this journey, and thank you for your attention.